Hi, everyone, and thank you for joining us today. The European Association for Cancer Research is very pleased to work in association with the Young European Hematology Association, yEHA, and the Young European Federation of Immunological Societies, which is EFIS, to invite you to this free publicly available virtual event where we're discussing the potential of CAR T cells for the treatment of hematological malignancies and solid tumours. The aim of this webinar is to bring together researchers from 3 different research fields that have a common goal to learn from each other. You can see from the program, the slide that's up there at the moment for the next 90 minutes. And I'm just going to keep it on whilst I speak. We've got 3 excellent speakers to discuss their research on CAR T, and it'll be followed by a Q&A session. Before we start the science, we're just going to have a couple of short introductions to each association, and then I'll talk to you about the Q&A, and then we'll get into the science, which is, I'm sure, what you're really interested to hear about. So my name's Andrew Binns, and I'm the membership manager for EACR. I know that many of our members are joining us now, so welcome back to all of you. If you've not heard of the EACR before and you work in cancer research, I invite you to join our community. You can find out more by scanning the code on the screen. We've got 14,000 members worldwide across 100 countries, and membership is basically open to anybody that works in cancer research, wherever they work, in any field, in any level. And 99% of our members said they will recommend EACR membership to other researchers. So that's a fantastic stat to hit you with. We exist to support cancer researchers in their work and their careers. This includes organising great conferences, providing access to different funding programs, educational and career webinars like this one, and tools to help people network and collaborate. On top of all the tangible benefits for many members, the best thing about being a member is the sense of being part of an international community with the same shared goal, which is to defeat cancer. My colleague Vivian is going to tell you a little bit about yEFIS.
First of all, good afternoon, everyone. So we are the Young European Federation of Immunological Societies, or short yEFIS, and our mission overall is to bring visibility to young immunologists, and on top of that, also to promote the networking between these researchers. However, in yEFIS, we are specifically interested in on young immunologists who are identified in our society as each researcher up to 10 years post PhD. And to fulfill our missions, we are actually organizing different events, webinars, as well as also other initiatives. For example, during the last couple of weeks, we focus on different career perspectives, which we call the 5 Career Fridays in Full. On the other hand, we're also doing in-person events. So we are currently very much looking forward to the yEFIS third symposium, which will take place in Prague next year. And if you're interested to join, feel free to already mark it in your calendar. The registration will be out soon. And all of the information, what we're actually doing, can be found online, either by following us on social media or on our website. And if you're interested, please feel free to join us and get involved in yEFIS. Thank you so much.
Thank you, Vivian. And Pedro will speak about the yEHA.
So good afternoon, everybody. Thank you for joining our webinar today. So I'll just briefly introduce the Young yEHA, or the junior component of the European Hematology Association. I am part of the committee, but we are an organization who is composed of early career professionals in hematology and for early career professionals. I don't have as nice organized slide as we just saw for the yEFIS, for example, but we have lots of events throughout the year, both in our congresses and independently, such as this webinar, where we try to highlight and promote early career researchers and provide opportunities for interaction, engagement in research and clinic, and for fostering interaction and mentorship opportunities. So if this sounds of interest and you'd like to get involved and you do anything related to hematology, please join us through the QR code you see on the screen. And thank you very much.
Thank you, Pedro. Okay, so before we start the science, I just want to mention the Q&A. So we will have 3 speakers. So you can click the Q&A button box at the bottom of your screen, or sometimes it's hiding at the top or with the 3 dots. If you could put the name of your speaker that would really help us to get the Q&A running smoothly when you want to ask some questions, because obviously they'll be in chronological order when they come in. So yes, the Q&A box, well, hopefully we'll have about 20 or 25 minutes to answer your questions at the end of the talks. And so, yeah, on to the talks. And our first one will be introduced by Maria.
Hi, hello everybody. My name is Maria Cafarel, and I am a representative of the EACR Early Career Researcher Council. And it's my pleasure today to introduce you to Sonia Guedan. Sonia is a brilliant scientist working on CAR-T in solid tumors. She's leading a group in IDIBAPS in Barcelona, Spain. She has been working with CAR-T for many years, I guess, Sonia. She did actually the postdoc at the University of Pennsylvania with Carl Jung in the laboratory that developed the first FDA-approved CAR-T therapy. She has been leading her own group since 2018. And she's actually as well a board member of the Spanish Society for Gene and Cell Therapy, and a member of the Immunotherapy and CAR-T Cell Scientific Committee of the European Society for Gene and Cell Therapy. Thank you very much, Sonia. We are very happy that you accepted the invitation.
Thank you, Maria, for your introduction and the organizers to inviting me to present today. So we can start. Thank you all for joining us today. So today I will be talking about next generation CAR-T cells, and I will focus in both hematologic malignancies and solid tumors. So so most of you probably know that CAR-T cells have produced very impressive results in patients with hematologic malignancies that lead to the approval of 7 CAR-T cell therapies that are available commercially. And however, there are still many patients with hematologic malignancies that either do not respond or relapse to this treatment, or either have hematologic malignancies that don't have a CAR that it's efficacious and it's available for this type of hematologic malignancies, and there are no CAR-T cells approved for solid tumors. And actually, the results in the first clinical trials with patients for solid tumors are far from what we are seeing in hematologic malignancies. We have seen some complete responses and some objective responses in a few clinical trials, but most of the responses are transient, and most of the patients actually don't have clear anti-tumor responses. So we have a long road to go, and and these are my disclosures. And today I'm gonna be talking on how can we improve the efficacy of CAR-T cells by focusing on 2 projects. One, focus on increasing T cell fitness. We need T cells to be fit to be able to eliminate the tumors and to avoid tumor relapses. And then we also need to avoid tumor escape. And I will be talking about these 2 projects today, but also I want to focus on the fact that we also have a problem of access. Because only 5% of the patients worldwide that could be receiving, that are eligible to receive commercial CAR-T, only 5% of these patients are actually receiving this treatment. So we have a problem to bring CAR-T cell therapies to all our patients worldwide. So touching on this, at Hospital Clínic de Barcelona and IDIBAPS, the institution where I'm working, we are advocating for developing academic CAR-T cells that can be used in point-of-care hospitals so that we can treat our patients locally. And so far, we have developed 2 academic CAR-T cells that are approved in Spain under hospital exemption. The first CAR is RE1, that is a CAR that recognizes CD19. And it has been approved in Spain for adults with ALL. It has always, a hospital exemption is a first step. So it means that any patient in Spain can come to Hospital Clinic and be treated in our institution with RE001. There are also other hospitals in Spain that are applying to get hospital exemption so that their patients can be treated at their point of care, right, at the different cities in Spain with this ARI-001. But at the same time, we have we want this CAR T-cell to be approved in Europe, so any European patient in need can use these CAR T-cells. And for that, we have received PRIME designation by the European Medicine Agency, which means priority medicine, meaning that that we have some free advice from experts so that we can get these CAR T-cells approved in a centralized manner as soon as possible. The second candidate is ARI-002, and these are CAR T-cells against BCMA. And they have also been approved in Spain for the treatment of patients with multiple myeloma under hospital exemption. Our next clinical candidates are ARI-003. These ARI-003 are dual CAR T-cells for the treatment of lymphoma, and I'm going to present this ARI-003 today. These dual CAR T-cells are now under clinical investigation in phase 1 clinical trial. We have treated more than 20 patients in 7 different hospitals in Spain. Then we have ARI-007. These are CD7 negative anti-CD7 CAR T-cells for the treatment of T-cell malignancies. And then we also have ARI-HER2, which are HER2 CAR T-cells for the treatment of breast cancer HER2 positive. For those 2 CAR T-cells, we have already obtained funding to do the clinical trials, and we are working, the preclinical studies are finalized, and we are working now with the regulatory agencies to get these clinical trials approved as soon as possible. Hopefully for ARI-HER2 would be early next year, and ARI-007 probably at the end of next year. So far, we have treated more than 500 patients at Hospital Clinic of Barcelona with these academic CAR T-cells with response rates very similar to those obtained with commercial CAR T-cells, which are 90% for acute lymphoblastic leukemia, 60% for multiple myeloma, and 50% for non-Hodgkin lymphoma. So as I say, I'm going to focus today on these 2 projects. I'm going to start with a project in the setting of hematologic malignancies, but it could be also applied to solid tumors to avoid tumor escape due to antigen escape. And the main question that we wanted to ask in this project is whether can dual targeting, if dual targeting of CD19 and BCMA could overcome antigen escape in lymphoma. And this project was published this year in Molecular Therapy. So this project, it's born based on the initial observation that CD19 expression is very high in the majority of B-ALL cases, but when we look at lymphoma patients, we see a lot of high inter and intrapatient heterogeneity of CD19 expression in the lymphoma B cells. And what the group from Crystal Mackall at Stanford observed is that patients that have high expression of CD19 tend to respond much better to CAR T-cell therapy than those patients that have low levels of CD19, that they either do not respond initially to the treatment, or they end up relapsing with tumors that express very low levels of CD19. So based on these results, this group and many others propose to start targeting 2 antigens at the same time so that we can avoid this tumor escape based on antigen on down regulation, because this is not, we're not losing the expression of CD19. Loss of antigen expression, it's mainly observed in B-ALL cases, but in lymphoma cases, what we see is a down regulation of this antigen. So based on the fact that we know that BCMA is expressed in non-Hodgkin lymphoma, and that we actually have a CAR targeting BCMA, so we were ourselves, can dual targeting of CD19 and BCMA overcome antigen escape in lymphoma and therefore enhance therapeutic efficacy. And BCMA is typically an antigen that is targeted in multiple myeloma, but is not a common antigen targeted in lymphoma. So we wanted to explore that possibility. So in order to develop dual CAR T cells, we have a few options, and we explore all of them. The first option is like just, so in order to target CD19 and BCMA, what we did is use our RE1 and RE2 CAR T cells that I already mentioned that are approved under hospital exemption in Spain. So we had a few options. The first option would be to combine these two treatments, like in a combination therapy, so they could be administered to the patient at the same time or maybe sequentially. However, this has the problem that we would have to do two different manufacturing processes, and this is very expensive. The other option that we have is to directly just generate dual CAR T cells, and for that we also have two options. The first option is to mix two lentiviral vectors. Let's say one lentiviral vector would express the CAR against CD19, and the other lentiviral vector, the CAR against BCMA. Mix these two lentiviral vectors and transduce T cells. And then what happens is that we end up with different populations of T cells. We would not have an homogeneous T cell product. We have T cells that have incorporated only the CD19 CAR, other cells that would have incorporated only the BCMA CAR, and some cells that would have both of them. Alternatively to this, we have the possibility to work with bisystronic CARs. Bisystronic CARs means that we have one single lentiviral vector that encodes for the two CARs separated by a T2A, for example, and then we only have one population of T cells that express both CARs. And finally, we also have the option of doing the tandem loop CARs. This is a single CAR that has two different single chain FB in tandem. So this is only one molecule, but two single chain FBs. And we compare all these possibilities. I will show you the results now, but just a spoiler, RE003, which is our final candidate, is made based on the co-transaction strategy, which is the one that ended up working better in our hands. So to begin with the project, we already started testing the co-transduction because was the easiest way to start with this project. And for the co-transduction, we have the vector encoding for the CD19 CAR, RE1, and the vector encoding for the BCMA CAR, RE2. And then the most obvious thing to do is to mix them at a ratio 1:1. But what we encounter when we mix RE1 and RE2 with the same MOI of lentiviral vectors, so at 1:1 ratio, is that actually the RE002 construct that targets BCMA was better expressed than the RE001. And because actually lymphoma patients are typically treated with CD19 CAR T cells, we were not that happy with that situation. We wanted to be at least 50-50. So what we did is to mix them at different ratios, and what we found is that when we mix them at a ratio of four times more RE1 than RE2, so 8 MOIs for RE1 and 2 for RE2, then we obtain balanced populations. And this was true for healthy donors and non-Hodgkin lymphoma patients. And within this population, you can see that we had balanced populations for all the CARs. So we're happy with that. And then we tested this in vivo models. For that, we use a Burkitt lymphoma cell line, and that expresses high levels of CD19. And then we also modify this cell line to express low levels of CD19. And we can see in these survival curves that treatment with RE0Z prolonged the survival of animals treated both in the setting of high antigen expression, but especially in the setting of low CD19 expression. So here we can conclude that that co-targeting of CD19 and BCMA could be a feasible strategy to generate dual CAR T cells. So the next question was, what's the best strategy to generate these dual CAR T cells? And for that, what we did is to generate CAR T cells for CD19, for BCMA, the pool, which is the mix of the two populations, RE3, which is the co-transduction group, having these 4 population, and then the besistronic, the tandem, and the loop CAR, that they all have a pure double positive population. And while we could obtain 60%, about 50% of CAR expression in all the groups, something that we found surprising is that when we analyze the vector copy number, so how many lentiviral vectors need to get integrated into the T cell to have this 60% of CAR expression, we realized that actually the tandem and the loop needed a lot of lentiviral vectors integrated in the T cell to have the same levels of CAR expression than the other ones. And we analyzed this further, and we realized that these 2 CARs were not that stable in the T cell membrane. They would downregulate very easily, and therefore they get we discarded that for further stimulation, for further investigation, and we focus on the other groups. So the first thing we did is to test these different groups in NSG mice with a Burkitt lymphoma expressing high levels of CD19. And under these conditions, we already saw that RE003 prolonged the survival of these animals better than the pool or the bisistronic or the single RE001 CAR T cells. Next, what we did is, because in our clinical trial, one of the cohorts we want to treat is Burkitt lymphoma, and that's why we are using this cell line. But then we have another cohort of patients that will have already been treated with CARs targeting CD19 and would have relapsed to these CAR T cells. So in order to mimic this scenario, what we did is we treat all the animals with RE1 targeting CD19, and when the tumors start relapsing, about 2 weeks, we treated them either with control CAR T cells, with RE1, with the pool, or with RE3, and then we analyze survival of this second dose. And what we can see here is that for the RE003, 6 of 7 animals got a complete response and got cured long-term, compared to only 1 treatment with RE1 or 2 treatments with RE1 or with the pool. So and finally, also to mimic this scenario, what we did is to generate tumors spheroid from patients that have been treated with CD19 CAR T cells and have relapsed. The first patient relapsed with a CD19 positive tumor. So his tumor was CD19 positive, BCMA positive, and under this condition, when analyzed killing or interferon gamma, we can see that RE1 in blue is very similar to RE3, and that RE3 is slightly better than the other combinations, the other dual CAR T cells. However, and the second patient that we analyze is a patient that relapsed with a CD19 negative tumor, but this tumor still expresses BCMA, and under these conditions, we can see how the RE1 CAR T cells do not release any interferon gamma. However, RE3 CAR T cells do get stimulated through the BCMA CAR and get good killing and good cytokine release. So based on this, the conclusions of this first part is that dual targeting of CD19 and BCMA effectively enhances tumor control in non-Hodgkin lymphoma. Co-transduction of 2 lentiviral vectors leads to stronger and more durable anti-tumor responses, and higher and more stable CAR expression, along with the coexistence of these 3 CAR-positive populations, might contribute to this improved efficacy that we observed. RE003 represents a promising therapeutic option for non-Hodgkin lymphoma relapsing after CD19 CAR T cell therapy, and based on this, a first-in-human phase 1 clinical trial is now ongoing to test the safety and efficacy of RE3 in patients with non-Hodgkin lymphoma. And now I would like to change gears a bit and focus now on the treatment of solid tumors, and specifically on T-cell fitness, but also a bit on tumor escape. And so we have seen that some patients with solid tumors that have been treated with CAR T cells do initially respond to this treatment, We have seen some objective responses, so we are optimistic. And in very difficult to treat tumors, also in patients that do not have any other therapeutic option, so with very advanced cancers, still we have seen some efficacy. So we are optimistic that CAR T cells can have therapeutic potential for patients with solid tumors. And one of a very obvious question, taking into account that many patients with solid tumors are treated with checkpoint inhibitors, is whether treating these patients, so whether CAR T cells will be susceptible to the inhibition through the PD-1, PD-L1 axis. And this is something that has been widely explored in the field with very contradictory results. In some cases, it seems that inhibiting the PD-1, PD-L1 axis seems to improve anti-tumor efficacy, and in some others, some other reports, published papers, it seems that there is no effect whatsoever in inhibiting this axis. So we were wondering for this project, are all CAR T cells equally vulnerable to PD-1, PD-L1 mediated inhibition? And something that was not explored in the field is whether the affinity of the single chain FV towards this their antigen could play a role in this susceptibility to the PD-1, PD-L1 mediated inhibition. And this is what we wanted to answer in this project. And what we did for that is we generated CAR T cells with two different CARs targeting HER2, one CAR that recognizes HER2 with high affinity based on the trastuzumab, and one CAR targeting HER2 with low affinity, which is the same CAR but with 2 point mutations that lower the affinity by 1,000 times. So, and then what we did is to expand CAR T cells, and we generated CAR T cells wild type knocked out for PD-1. And then in parallel, what we did is we established a model so that we had tumor cell lines. We started with SQV3, which expresses HER2 at high levels. And then what we did is we knocked out PD-L1s, and then we overexpressed PD-L1 at low or high levels to have a model to study this axis, the effect of this axis on CAR T cells. So you can see that we expanded, both CARs are expressed at similar levels in different healthy donors. We could achieve PD-1 knockout for both low and high affinity CAR T cells, and you can see here by flow cytometry. So then, taking advantage of this model, we decided to go in vivo, and we implanted animals with these SQV3 tumors that are knocked out for PD-L1, and then we treated with the HER2 low affinity CAR T cells in red, and with the same low affinity CAR T cells that have been knocked out for PD-1, and in the absence of PD-L1, these two CAR T cells behave very similarly. However, when we did this experiment in animals with tumors that express low levels or high levels of PD-L1, we can see that under these conditions, conventional CAR T cells lose their anti-tumor efficacy, and then tumors are able to escape CAR T cell treatment. However, when we knock out PD-1, then all these animals have complete responses after this treatment. So indicating that targeting this axis in low affinity CAR T cells could improve anti-tumor efficacy. But what happened when we do the same experiment but with high affinity CAR T cells? What we observe is no differences in the PD-L1 knockout animals, but also no differences in the PD-L1 high animals. And we repeated this experiment at different doses, and we never see any differences between knocking out PD-1 or not. Actually, these CAR T cells didn't seem to get inhibited by these high levels of PD-L1. We also repeated this experiment with wild-type SQV3, which means they don't initially express PD-L1, but after CAR T cells get activated, they would upregulate PD-L1 at endogenous levels, and then we can see here how, again, in the case of the low-affinity CAR, knocking out PD-1 makes a huge difference, while in the wild type, while in the high affinity CAR, we still didn't see any difference between the knockout PD-1 or the wild type CAR T cells. So next we wanted to understand what's the rationale behind that, what's the mechanism by why high affinity CAR T cells escape, are not inhibited by this pathway. And we did some transcriptomic analysis using a nanostring panel. This nanostring panel analyzes only 380 genes, so it's not RNA sequencing, but it gives a good sense of what's happening. And when we analyze the differences between knocking out PD-1 in low affinity CAR T cells versus wild type CAR T cells, we can see that we found 13 genes that were upregulated in the knockout PD-1 CAR T cells and 20 genes downregulated. But when we did the same experiment in the high affinity CAR T cells, we barely see any gene that is differentially expressed between the knockout PD-1 and the wild type CAR T cells. So then we focus on these genes that are regulated when we knock out PD-1 in CAR T cells, and we found a lot of cytokines and activating genes, immune genes. And based on that, we decided to analyze cytokine production at single cell level using isoplexis. And these are the low affinity CAR T cells. The first thing we see when we analyze cytokine expression is that PD-1 knockout CAR T cells cluster all together compared to the mock CAR T cells. However, when we analyze the same features in the high affinity HER2 CAR T cells, then we can see how they all cluster together, so there don't seem to be any differences between the mock or the PD-1 knockout. And then we analyze the percentage of polyfunctional cells and the polyfunctional strength index in low affinity CAR T cells, and found that when we knock out PD-1, knocking out PD-1 increases the percentage of polyfunctional cells in both CD4s and CD8 T cells, and also the polyfunctional strength index. However, when we did the same experiment with a high affinity CAR, we can see that knocking out PD-1 doesn't really improve that much these CAR T cells, probably because they are already polyfunctional to start with. So as a conclusion of this second CAR, low affinity CAR T cells are more sensitive to PD-1, PD-L1 axis-mediated innovation compared to high affinity CARs, and PD-1 disruption enhances the functionality of low affinity CAR T cells, while it does not provide an advantage to high affinity CAR T cells. And with that, I would like to acknowledge everybody from my group. I presented data from Alba Rodriguez Garcia, Irene Andreu, the PD-1, PD-L1 story, and Nina Barceló and Mireia Bachiller for the RE003 CAR T cells, and then all the clinical trials and the CAR T cell program at IDIBAPS Hospital Clinic is led by very key members of the institution. Álvaro Urbano Izpizua was the chief of hematology department, Manel Joan, the chief of immunology, and Aleix Prat was before the chief of oncology, now the chief of hematology, and Julio Delgado, who is leading most of the clinical trial with our CAR T cells. So thank you very much, all of you, for listening today, and I will be happy to take any questions at the end.
So thank you very much for the fantastic talk, Sonia. That was excellent. So we have a question and answer session all together at the end of the webinar. So now I would like to introduce our next speaker, Dr. David Stahl. If you could please turn your camera and mic on. So David is resident physician at University Hospital Cologne in Germany. He first studied medicine in Bonn and Cologne and had the highest honors in his doctorate of medicine. And since 2020, he has been specializing in hematology and oncology at University Hospital Cologne as well. So he joined Professor Ulrich's research group in 2021, where he is currently a postdoctoral researcher. And as a physician scientist, David focuses on high-dimensional profiling of tumor specimens to understand therapy resistance. And now we'll hear soon about his work in CAR T-cell mediated anti-lymphoma immunity. So please, David.
Okay. Hi, everyone. And first of all, thank you so much, Pedro, for your very kind introduction. It's my great pleasure to participate in today's webinar and to provide you an overview about our recent work. And the project I'm going to present within the next few minutes is about lymphoma-associated myeloid monocytic cells and how these cells can potentially mediate CAR T-cell resistance. You're all very well aware of, and Sonia already outlined it very well, that CAR T-cell therapy revolutionized cancer treatment, and especially the treatment of B-cell malignancies, achieving long-lasting and deep remission in those entities. And this success led to the approval of CAR T-cell therapy for a variety of B-cell malignancies, beginning in 2017 with the approval for B-ALL and large B-cell lymphoma. And in 2022, it was approved for the second-line treatment of high-risk DLBCL patients based on large clinical trials, such as the ZUMA-7 trial, demonstrating a survival benefit of those patients treated with CAR T-cells compared to those receiving the standard of care. However, and this is one challenge and one problem we are facing, approximately half of those CAR T-cell treated patients do not remain in long-term remission, as we have learned from long-term follow-up from clinical trials such as the ZUMA-1 trial, but also from real-world observations. And therefore, I would like to briefly introduce potential mechanisms of CAR T-cell failure and also to provide some background for the project I'm going to present. So first, on the B-cell lymphoma side, and Sonia already mentioned, immune escape mechanisms and antigen loss, antigen down-regulation can contribute to CAR T-cell resistance. On the T-cell side, it's known that a CAR T regulatory phenotype can be associated with a worse clinical outcome after CAR T-cell therapy, and the development of T-cell exhaustion, CAR T-cell exhaustion, can lead to a reduced and lower cytotoxicity towards the target cells. Finally, the lymphoma microenvironment plays a critical role in mediating CAR T-cell responses and CAR T-cell resistance. For example, the recruitment of immunosuppressive cells can directly impact CAR T-cell efficacy, and here our project is focusing on specifically on the myeloid monocytic cell compartment and how these cells can impair CAR T-cell function. So the aim of our work of our study is to detect signatures which are related to refractory outcomes after CAR T-cell therapy. To this end, we first analyzed a B-cell lymphoma patient cohort treated with CAR T-cells at our institution, and we were also able to obtain tissue biopsies before and under treatment. We analyzed those lymphoma specimens using bulk and single-cell transcriptomic and proteomic analyses to finally describe the lymphoma microenvironment of durable and non-durable responding patients, with the ultimate goal to identify potential therapeutic targets which can be combined with CAR T-cell therapy in future. So we first identified two distinct prognostically relevant patient subgroups. So patients achieving a complete remission 6 months after CAR T-cell therapy could benefit in long term, and we classified those patients as durable responders compared to the non-durable responders here shown in red. So how do these two patient subgroups distinguish from each other? I would like to first show you the bulk transcriptomic data of 24 patients, and these lymphoma specimens were obtained before CAR T-cell therapy, divided into the non-durable responding patients and the durable responding patients. And here we observed that genes related to lymphoma-associated myeloid monocytic cells and the cell compartment, we call this the LAM gene signature, such as CD11b, CD68, and CD14, showed a higher expression in those non-durable responding patients, and this was accompanied by a hypoxic lymphoma microenvironment. We finally correlated this LAM gene signature with patients' outcome, and here we saw that those patients with a high LAM gene signature prior to CAR T-cell therapy were at a higher risk with a shorter progression-free survival compared to those patients with a low LAM gene signature before CAR T-cell therapy. So we next aim to validate this LAM gene signature at a single cell level. So which cells mostly contribute to this LAM gene signature? For this, we performed single-cell RNA sequencing of 7 patients, and again, these biopsies were obtained before CAR T-cell therapy. We could identify a shared lymphoma microenvironment mainly composed of T cells, but also consisting of a distinct myeloid monocytic cell cluster. And these LUM cells showed expression of markers which we knew from the bulk LUM gene signature, such as CD68 and CD14, but most importantly, showed high expression of CSF1R. And I would like to briefly introduce CSF1R, which is a receptor tyrosine kinase being essential for the development, the differentiation, and the expansion of those myeloid monocytic cells. CSF1R expression increases from the hematopoietic stem cells towards the more activated, the more differentiated myeloid cell types. And it's known that CSF1R, here shown as CD115, is expressed on myeloid cells at the tumor site. Furthermore, we and others have shown that CSF1R signaling is mediated by AKT-mTOR pathway activation, is enriched in LUM cells, and decreases upon CSF1R inhibition. So back to our single-cell data, we further characterized those LUM cells, showing a high and quite specific expression of the LUM gene signature, CSF1R, and also other key markers such as CD14 and CD68 were expressed. Finally, we observed higher CSF1R expression levels in those LUM cells derived from non-durable responding patients compared to LUM cells from durable responding patients. So at this point, we were able to identify those CSF1R positive LUM cells at a single cell level. And to further strengthen this finding, we performed a multiplex immunohistochemistry staining for CSF1R in black, CD14 in purple, and CD68 in cyan. And here we observed that those CSF1R, CD14, CD68 positive cells also infiltrate the lymphoma microenvironment at a proteomic level. So based on this pilot cohort or pilot study, we then aimed to validate this in a larger cohort of patients. We performed imaging mass cytometry, again on lymphoma biopsies taken before CAR T-cell therapy, and these analyses revealed that the durable responding patients showed high infiltration of T cells and lower LUM cell infiltration, whereas the non-durable responding patients were mainly characterized by high LUM cell infiltration. And when we correlated this LUM cell infiltration with patients' outcome in this IMC dataset, we observed an association with a shorter progression-free survival. In one patient of this IMC dataset, we were able to analyze tissue biopsies 2 days after CAR T-cell therapy and 1 month after CAR T-cell therapy when the lymphoma had progressed. And in both samples and at both time points, we were able to see that the myeloid, the LUM cells here shown in red, were closely clustering together with the T cells here shown in cyan, and especially in the areas of the blood vessels. So indicating a relevant interaction between CAR T cells, and LUM cells within the lymphoma microenvironment. Based on the bulk transcriptomic data, we have also learned that those patients with a high LUM gene signature showed lower T cell infiltration, and therefore we combined both LUM cell infiltration and T cell infiltration in this IMC data set, and thereby we could identify a very high-risk patient subgroups characterized by high LUM cell infiltration and low T cell infiltration, and with a very short progression-free survival. So based on these observations, we were very interested to dive deeper into this LUM cell T cell interaction. So how do these two cell types interact with each other? And to address this question, we first revisited the single cell data from human and mouse lymphoma. In both data sets, we identified LUM cells and T cells, enabling us to perform cell-cell interaction analyses. And using the tool CellPhoneDB, we were able to identify ligand receptor pairs which may be driver of this LAM cell T-cell interaction. So which LAM cell ligands do interact with T-cell receptors, and the other way around, which T-cell ligands do interact with LAM cell receptors. And here I would like to highlight that we were able to identify known immunosuppressive ligand receptor pairs such as galectin-9 TIM3 and CD86 and CTLA4 driving or mediating LAM cell T-cell interaction. But I would like to draw your attention to the prostaglandin E2, PGE2 finding, which we had in both mouse and human data set. So it seemed that LAM cells communicate with T cells by secretion of prostaglandin E2, which then interacts with the corresponding PGE2 receptors EP2 and EP4 on the T cell side. So based on these in silico data, we then aimed to validate and confirm LAM cell T cell interaction by using co-culture experiments. And for this, we first generated human LAM cells ex vivo upon 7 days of culture, and these LAM cells nicely resembled the patient-derived LAM cell phenotype, which we identified in the transcriptomic data, showing high and quite high expression of those LAM genes, and also key markers such as CD14 and CD68, and most importantly, CSF1R were upregulated in those LAM cells. Furthermore, those CSF1R positive LAM cells showed high expression of those immunosuppressive ligands, which we previously identified in the CellPhoneDB analysis with the synthase of PGE2, galectin-9, and CD86 being upregulated both at a transcriptomic and proteomic level. So we next co-cultured those CSF1R positive LAM cells together with CD19 CAR T cells and diffuse large B-cell lymphoma. And in this triple co-culture here shown in red, we observed increased B-cell lymphoma survival and decreased T-cell expansion. Furthermore, the activation of CD8 and CD4 T cells was reduced. So these first co-culture experiments revealed an immunosuppressive effect of those CSF1R positive LAM cells in the context of CAR T cell therapy. And at this point, we remember the EP2, EP4, PGE2 finding, and we repeated these co-culture experiments using dual knockout CAR T cells. And these dual knockout CAR T cells harbor a specific knockout for the PGE2 receptors EP2 and EP4, rendering them insensitive to the LAM cell-derived PGE2. And in these co-cultures using those dual knockout CAR T cells, we were able to at least partially overcome this immunosuppressive effect of those CSF1R positive LAM cells, indicated by increased B-cell lymphoma killing, increased T-cell expansion, and also the activation of CD8 and CD4 T cells was enhanced. Furthermore, we observed higher secretion of pro-inflammatory cytokines such as interferon gamma, IL-2, and TNF-alpha in those co-cultures using dual knockout CAR T cells. So based on these co-culture experiments, which revealed an immunosuppressive effect of those CSF1R positive LAM cells, and the patient data where we found these LAM cells being associated with a worse clinical outcome, we were highly excited to test the concept of targeting those CSF1R positive LAM cells together with CAR T cell therapy in vivo. So I would like to first mention that CSF1R inhibitors are clinically tested. They are generally well tolerated and already FDA approved. So we treated immunocompetent DLBCL bearing mice with murine CD19 CAR T cells, and from day -2 to day 28, those mice also received CSF1R blockade. And on the last couple of slides, I would like to now show you the changes and the differences we observed in those combi-treated mice. So first, at a transcriptomic level, CSF1R was downregulated in combi-treated mice, and we also observed a downregulation of the bulk LAM gene signature, which we previously detected or identified in the human data set in or upon CSF1R blockade plus CAR T-cell therapy compared to those mice only receiving CAR T-cell therapy. Furthermore, we observed a shift towards a more immunosupportive, a more T-cell enriched lymphoma microenvironment, and this finding could be also validated by imaging mass cytometry, where we observed higher CD4 and CD8 infiltration in those combi-treated mice, whereas CAR-T mono-treated mice were mainly dominated by the lymphoma, which is B220 positive, as we can also see in the B220 positive immunohistochemistry, showing these enlarged spleens with a high lymphoma infiltration. We further could observe that this CSF1R inhibition could restore the follicular T-cell architecture in those diseased spleens from combi-treated mice, whereas in CAR-T mono-treated mice, the CSF1R positive cells here shown in red were in close proximity to the CD3 positive T cells. And we further characterized those T cell clusters with a core of CD8 T cells, which were surrounded by CD4 T cells. And in the areas in between those T cell clusters, the LAM cells were distributed, here shown in blue. And this was confirmed by spatial analyses showing greater distances between LAM cells and T cells in those combi-treated mice compared to CAR-T mono-treated mice, indicating a less frequent, a less direct cell-cell interaction between LAM cells and T cells in those combi-treated mice. So finally, we followed up these treatment cohorts using MRI, and here we observed good and deep responses in those combi-treated mice compared to the control groups. And most strikingly, those mice receiving CSF1R inhibition and CAR T-cell therapy showed a prolonged progression-free survival and overall survival compared to the control group. And in some cases, we observed really long-lasting and deep remissions. So with this, I would like to conclude and summarize. We analyzed B-cell lymphoma patients treated with CAR T-cells using high-dimensional profiling of the lymphoma microenvironment to finally characterize the lymphoma microenvironment of durable responding patients and non-durable responding patients. And here we identified that the lymphoma microenvironment of non-durable responding patients showed lower T-cell infiltration and higher LAM cell infiltration. Our co-culture experiments revealed an immunosuppressive effect of those CSF1R positive LAM cells in the context of CAR T-cell therapy, and this immunosuppression was at least partially driven and mediated by PGE2 and the corresponding receptors EP2 and EP4. And finally, in an autochthonous mouse model, when we treated immunocompetent DLBCL-bearing mice with murine CD19 CAR T cells in combination with CSF1R blockade, we observed synergistic treatment effects with a shift towards a more immunosupportive lymphoma microenvironment with increased treatment responses and a prolonged survival. And based on these findings, we feel that the combination of CSF1R inhibition and CAR T-cell therapy should be also evaluated in high-risk patients suffering from relapsed refractory B-cell lymphoma. So with this, I would like to thank everyone who is and was involved in this project. This is a huge team effort. Thanks to all collaborators, thanks to all co-authors, and thanks to Roland Ulrich and his research group. Thanks for your attention, and I'm happy to take some questions after Tobias' talk. Thank you.
Thank you, David, for a really wonderful talk. My name is Jan Emsig, and I'm delighted on behalf of Young yEFIS to introduce Dr. Tobias Weiss, a physician scientist at the University Hospital and University of Zurich in Switzerland. His research focuses on developing novel diagnostic and therapeutic strategies for malignant brain tumors, including innovative cancer immunotherapies, liquid biopsy approaches, and functional precision medicine. Dr. Weiss has successfully translated pioneering cancer immunotherapies from preclinical discoveries into clinical trials in patients. His work has been recognized with numerous prestigious awards, including the Pfizer Research Prize, the George Friedrich Goetz Prize, and also the ERC starting grant. So thank you very much for accepting our invitation, and please take it away.
Yeah, thank you very much. I share my screen. Hello, everybody. Thanks a lot to the organizers for the invitation, and thanks, Jan, for the kind introduction. Can you see my screen?
Yes, perfect.
Okay, super. So it's a great pleasure to present or give you an overview about novel CAR immune cell strategies against glioblastoma. Just to bring everybody on the same page, so the disease target is glioblastoma. That's the most common and most aggressive primary brain tumor in adults. Here in the lower left, you see a typical MRI scan from a patient treated in our department. And this white mass here is the contrast-enhancing tumor that is infiltrating the brain. It is typically treated with a combination of surgery, chemotherapy, and radiotherapy. But as you can see on the right here from this survival curves from patients with glioblastoma from the canton of Zurich, so the area where I live and work at the moment, the survival is really poor and in the range of 15 to 20 months, and it has not really improved within the last decades. So there is an urgent unmet medical need. And of course, there's big hope in immune cell therapies, predominantly CAR cell therapy. At the top, you see the current concept, and I guess all of you know that classically they are ex vivo engineered cells that are then re-administered back to the patient and that are able to recognize and kill cancer cells. Now, against glioblastoma, this is an emerging field and it's dominated by CAR T cells, but we should not forget there are also other immune cell types that can be equipped with CAR receptors and can be re-administered back to the patients, such as CAR NK cells and CAR macrophages. And actually, against glioblastoma, there is also one CAR NK cell trial ongoing at the moment in Germany. This uses a cell line and not primary cells, but still, this is also something that is really pushed at the moment. The conclusion from all these efforts with CAR T cells, CAR NK cells, and there's no trial with CAR macrophages so far, is that it is actually safe to administer these engineered cells directly into the tumor, so in the brain, in patients with glioblastoma, but it is so far really has limited activity. And the challenges are four. So first, the anatomical location of the tumors in the brain. Second, the antigen dilemma, and Sonia elaborated on this already. The immunosuppressive tumor microenvironment, and Daniel mentioned this. And then we have huge requests on infrastructure, time, and costs. And I will show you solutions for all these challenges in the next slides. So let's start with the anatomical location. So these tumors are seated deep in the brain. And if we give CAR T cells intravenously in mouse models and track them, just a minority of the cells reach the tumor site, and therefore we have just a limited survival effect. And therefore, standard nowadays is to administer CAR T cells directly, locally, intratumorally into the tumor in patients. This has a better survival benefit. Still, just a fraction of, in that case, mice can be cured. So there is definitely a need to improve the activity. And this approach is now standard also in patients. So we typically have a catheter that is implanted with a tip ending in the tumor or in the CSF space. And then the CAR T cells can be repeatedly administered through these catheters with actually a good safety profile. So this problem is solved with this local administration. Coming to the next problem, which is the antigen dilemma. And on the left side, you see the current targets for CAR T cell therapy in glioblastoma. What is striking is that there is always one name, meaning these are single antigens. And as Sonia already elaborated before, a huge problem is antigen escape. And this is indeed what's happening in patients. So here on the right, you see tumor tissue from a patient with glioblastoma treated with CAR T cells. Before CAR T cell therapy, the target antigen, in this case, interleukin-13 receptor alpha 2, is highly expressed. However, after CAR T cell therapy, the tumor is still there, but it's antigen negative. So basically, we have selected for the cancer cells that do not express the target. And to overcome this, of course, we nowadays target multiple antigens with one CAR T cell product. And as Sonia mentioned, one strategy for this is to combine different CAR T cell domains, or also in one product, or mix two together. So basically, if you have classical antibody-derived binding domains, they can be integrated in one vector. So we have co-expression of different antibody-derived binding domains. So this is one approach. And then there's an alternative approach of what is called unconventional CAR designs. So here, the tumor binding domain is not derived from an antibody, so a single chain fragment variable, but it's more derived from unconventional receptors. And these receptors, and here are two examples. One receptor is called NKG2D, and one receptor is called DNAM1. These are just two examples. But the beauty of these receptors is they can promiscuously bind multiple tumor antigens. So one receptor can bind multiple tumor antigens. In case of NKG2D, it's actually 8 antigens that can be bound simultaneously with this one receptor. In the case of DNAM1, it's 2 tumor-associated antigens. And we rather pursue this approach with this unconventional CAR designs and focus mainly on the NKG2D CAR. These multi-targeting approaches have entered the clinic already. So this is an example from a clinical trial. It's a phase 1 dose-finding clinical trial in patients with recurrent glioblastoma. And they have been treated with CAR T cells that recognize 2 antigens. One is EGFR, so epidermal growth factor receptor, and one is interleukin-13 receptor alpha 2, highly expressed in glioblastoma. And here this is expressed in one vector. The conclusion is that this multi-targeting CAR T cell product leads to objective responses in patients, and it's safe. Here, this report includes 6 patients, and the clinical trial is ongoing. Another strategy to broaden actually the cancer cell recognition capability of a CAR T cell product is to engineer the CAR T cells further. And this is an approach where the CAR T cells express a CAR receptor, but they also secrete T cell engaging molecules, so like BiTE molecules that essentially bind cancer cells and stimulate bystander T cells that are also present in the tumor microenvironment. Also, this has entered the clinic, has been tested in a phase 1 clinical trial. Also here, objective responses in patients with glioblastoma, and it seems to be safe. Now, as Sonia mentioned, and David as well, the main problem is that although we have objective responses with these approaches, they are short-lived. So after a couple of weeks, all patients basically will have a tumor progression. And the reason is that the tumor microenvironment is what we call immunologically cold. So it inhibits rapidly the CAR T cells and other immune cells. The reason for this is 2. So first of all, glioma cells have a very low number of mutations, and therefore they cannot recognized by T cells as foreign, and therefore we have a very poor T cell mediated response against glioma cells. And the second reason is coming from the environment. So glioma cells secrete a lot of factors, attract a lot of immunosuppressive cells that then inhibit basically CAR T cells and also an anti-tumor immune response. And really the question is, how can we shift this immunosuppressive microenvironment into a more immune active environment so that we also have a durable anti-tumor immune response? So one strategy is basically to suppress the inhibition of the T cells themselves in this immunosuppressive environment. This can be done by combination therapies of CAR T cells with what we call immune checkpoint inhibitors. And this here is an example in mice. So here we treated mice with DNAM-1 CAR T cells. So this is another unconventional receptor, DNAM-1, that can bind to tumor-associated antigens. And the problem is that CAR T cells express a co-inhibitory receptor named TIGIT, and this competes with the antigen binding of DNAM-1. And therefore, it has also a higher affinity. And when then the CAR T cells bind through TIGIT, they are basically inhibited. So TIGIT is highly expressed in these CAR T cell treated mice. And if we basically then combine CAR T cell therapy with anti-TIGIT antibodies, we can really improve the activity and also the number of long-term surviving mice. So this is one strategy. The second strategy is to further engineer the CAR T cells so that they basically activate also the tumor microenvironment. And there are different possibilities for this. So in this study, done in collaboration with colleagues from Basel in Switzerland, we engineered the CAR T cells further so that they secrete a small molecule, and this small molecule has the name sGRP. It basically stimulates tumor-associated macrophages so that the macrophages can also start fighting the cancer. And it basically blocks the SIRP-alpha anti-CD47 axis. And what we can see in this survival curve, that basically CAR T cells that co-express this macrophage enhancing molecule really lead to an improved survival. The other option to further engineer the CAR T cells is a way so that they co-express pro-inflammatory cytokines. And cytokines are very potent, so they act on innate and adaptive immune cells and really can convert the immunosuppressive environment into a more immune active one. So here we engineered CAR T cells that carried the multi-targeting NKG2D CAR so that they can co-express two pro-inflammatory cytokines, in this case interleukin-12 and interferon alpha-2. And what we can see in vitro in co-culture killing assays is that the CAR T cells that co-express the cytokines have the highest tumor cell killing activity. And they also have the best activity in vivo in orthotopic syngeneic glioma-bearing mice. We also tested then these cytokine co-expressing CAR T cells ex vivo in glioblastoma patient samples. So if we spike in basically CAR T cells, we cannot reduce the number of glioma cells. So they are really not active in this immunosuppressive soup, let's say. But if we have the CAR T cells that co-express the pro-inflammatory cytokines, we really can kill glioma cells and then basically unleash their activity. So the cytokine co-expressing CAR T cells, of course, not only act on the CAR T cells, but they also act on the bystander immune cells, so the cells that are in the microenvironment. And here, the cytokines predominantly activate and promote CD4 and CD8 T cells, and they basically shift the T cell states, so they are less exhausted and more activated if we treat mice with the CAR T cells that co-express cytokines. So this is a very promising approach, and it's really a hard weapon to overcome this immunosuppressive environment, and this is also what is moved in the clinic. Now, I mentioned that not only CAR T cells is an emerging topic, but also other immune effector cells such as CAR NK cells and CAR macrophages. And we asked the question if other cells are superior in terms of their anti-glioma activity. So what we did is we generated CAR T cells, CAR NK cells, and CAR macrophages. We used for this mRNA technology. So we transfected mRNA that encodes for this multi-targeting NKG2D CAR, and then basically performed co-culture assays with glioma cells. And in vitro, the conclusion is that the T cells really just can kill if they are equipped with a CAR. NK cells can kill actually cancer cells no matter if they carry a CAR or not. and CAR macrophages have very little direct anti-tumor activity. When we inject these in glioma-bearing mice, so mice that have glioblastoma in their brains, we observed that CAR T cells have the best tumor migration properties. So we find if we inject similar numbers intravenously, the highest number of CAR T cells compared to CAR NK cells or CAR macrophages. And what was very interesting is that each of these different effector cells has a different effect on the tumor microenvironment. So for example, if we treat glioma-bearing mice with CAR T cells, they recruit granulocytes, for example, or B cells. Whereas if we treat, for example, with CAR macrophages, they rather attract NK cells and, for example, activate microglia. However, in vivo, they have all of these cells really have very limited activity on their own. So if we inject them in mice, the CAR T cells perform best, but as you can see, just a small fraction of these mice is cured. And again here, and for all cell types, if we support them with pro-inflammatory cytokines, so if they co-express interleukin-12 and interferon alpha-2, we can definitely unleash their activity, and then they have a predominant anti-tumor activity with a large number of glioma-bearing mice. And as a last slide, I just want to show you that not only T cells are good for engineering. So this is just an alternative approach. It's not based on CAR equipment, but basically what we did here is we used macrophages to deliver drugs to cancer cells. The rationale for this is that solid tumors have a large fraction of macrophages, so tumor-associated macrophages. And glioblastoma, for example, it's up to 50% of the tumor-infiltrating immune cells. And here what we did is we loaded these basically monocyte-derived macrophages with drug cages. So these are protein cages that carry drugs. And then when these monocytes are administered, they are basically attracted by cancer cells. And the monocyte drug conjugates, how we call them, transfer the drug cage into the cancer cells, which is released and can kill the cancer. This is just a summary of the preclinical data. So we have shown that if we co-culture this drug carrying macrophages with cancer cells, and the cancer cells are highlighted here in red, the drug is labeled fluorescently in that case here in green. So we basically find these drug cages in the glioma cells over time, and we can kill the cancer cells. However, we don't kill healthy cells. So it seems to be really have a specificity for cancer cells. Now, this macrophage drug conjugates also have a survival benefit in, again, glioma-bearing mice, and they stimulate anti-tumor immunity. So if we profile tumors after treatment, we have more tumor-infiltrating CD4 and CD8 T cells. Also, this goes into the clinic, and here hopefully a clinical trial will start next year. Same concept, local administration of this product, and then we will do an accompanying translational research program. So with this, I conclude and just want to say, so far, unfortunately, no immunotherapy has demonstrated a survival benefit against glioblastoma. But CAR immune cell strategies are very promising, and the main efforts at the moment aim to address the antigen dilemma, so multi-targeting approaches, and then approaches that reprogram the tumor microenvironment into a more immunological active one. They are very exciting approaches that are actually translated into the clinic next year, and we have to see if they are safe and effective. So with this, I'm at the end and want to thank everybody involved in these projects, and particularly Mio-san, who is actually part of the audience here, who has really pioneered the CAR PBMC platform and the macrophage platform. Thanks a lot.
Thank you very much, Tobias, and to all of our speakers for your excellent talks. I know it's generated lots of questions for discussion. We're a little bit short on time, so I'm going to get straight into those questions as soon as I can. Anybody's got another one to add, just make sure you name the speaker at the start of the question. And we're going to try and take the questions from each talk in order, if we can. and we'll see if we can allow the person that wants to ask a question to talk via their mic. So I'll try and switch that on. I think we can start straight away. So Maria, can you tell me the question, the person who's asking the first question?
Yeah, thank you very much to all the speakers for these excellent talks. So we have, as Andrew mentioned, many questions. So we will try to answer them quickly. And the first that I choose for Sonia is from Laura Martinez. Give me a second. So Laura is asking 3 different questions that actually summarize other questions. And the first one is RE3 intended to be used as an initial treatment or as a post-relapse therapy? And in this case, will CD19 expression be evaluated?
For now, in the clinical trial, we have different cohorts. One of them is for patients that have relapsed to CD19 therapies. The other ones are for patients that don't have approved CAR T-cell therapies like Burkitt cell lymphoma or even other types. And yes, CD19 and BCMA expression will be analyzed before treating these patients. So for now, is the last therapeutic option, right? It's for patients that don't have any other therapeutic option.
Thank you very much, Sonia. I may come back to Laura's question later, but now I'm going to switch to one question for David. David, are you there? Can you open your camera and your micro, please? So the question says, David, do you have any genomic transcriptomic data of the patients prior to CAR T cell therapy to link those non-durable patients to any cause? Or do you have any initiation regarding why different TMA occurs between durable and non-durable response patients? Thank you.
Hi, I am there. I unfortunately cannot start my video. I think it's blocked by the host, but I can maybe start to answer this question. So this is a key question and a great question, which we asked and were much interested in. So how do these non-durable responding patients and durable responding patients distinguish with regard on the lymphoma microenvironment before CAR T-cell therapy? And we observed, we observed that that in this project, the myeloid monocytic cell compartment impacts responses, and therefore it seems that that it also it's worth it to target those LME components within the data. So we do not have genomic data, we have the transcriptomic data I showed you on the first slides with the 24 patients, but I think that's very interesting to go deeper into the tumor microenvironment and its associations with response, and then back and targeting these components.
I have a question for Tobias from Lukasz Artemovich. So if you chose to deliver CAR Ts, not intratumorally, but intravenously, would you need to deliver higher numbers and higher doses to get the same kind of response, or is it impossible for cells to cross the blood-brain barrier?
Yeah, so this is really, so a majority actually gets stuck in the liver, right, and in the lungs. So it doesn't actually really help if you administer higher numbers. What you rather need to do is to further engineer these cells. So for example, if you co-express chemokine receptors that promote migration towards the tumor, this is one option. But you never get as many as possible cells than compared to the local administration. That's why this at the moment is the standard.
Thank you, Tobias. I go now for Sonia. I have a question for you. Sonia, I will summarize two questions. 2 people are asking, Geoffrey and Lucas, if you have compared your PD-1 knockout to actually anti-PD-1 treatment, and what was the result?
Yeah, we also, all these experiments I show you with the PD-1, we did them as well with blocking antibodies targeting PD-1 or PD-L1. In vivo, it's a bit more tricky, but in vitro, the results are very similar, and in vivo should be, but there are some interferences from antibodies binding to macrophages, and the model is not great. But the answer is, yeah, we can reproduce what we see with the PD-1 knockout with the blocking antibodies.
Thank you. I have a question now for David. And it says, "Dear David, thank you very much for your work." It's from Inés Pinto, the question. "We know that blocking immune pathways such as PD-1 or CTLA-4 can trigger autoimmune responses due to the loss of immune tolerance. In the case of CSF1R, has it been evaluated whether its blockade could cause similar effects? If so, how are these potential side effects managed?"
Yeah, that's a very good question and very important question. So what we can say is that this treatment in vivo was generally well tolerated. We didn't observe any side effects which we had to discontinue the treatment. But we have to say that we did not have the right model to monitor such side effects, such as cytokine release or neurotoxicity. But there is data, for example, from the laboratory of Robert Zeiser in Freiburg, and they have models to study neurotoxicity in CAR T-cell treated mice, and they evaluated CAR T-cell treatment together with CSF1R blockade, and they could show that neurocognitive function is increased in those CAR T-cell treated mice. So, and also in our transcriptomic data, we see that those cytokines involved in cytokine release syndrome are downregulated upon combi treatment. So we think it could be also making the side effects better and reduce side effects, and also to increasing efficacy of this treatment. Good question. Thanks.
So again, for Tobias, when you electroporate your PBMCs, do you see different levels of CAR expression in different subtypes, and how persistent is the RNA expression considering that it's not incorporating?
So it works equally effective across all effector cell types. That's the first answer. The second is it lasts for up to 5 days approximately. So it's just a transient expression. And yes, conceptually, the idea is really just to have this transient anti-tumor killing by CAR T, NK, and macrophages, but then to deposit cytokines so that the endogenous immune system takes over. And this is really what then confers a durable response.
Thank you very much, Tobias. Andrew, as you are the organizer, it's already 3:30 here in South Europe. Do we have 5 more minutes? Can the speaker stay for 5 more minutes? Sonia, David, and Tobias? Yes? Perfect. So we will continue for 5 more minutes. So we will try to be very quick in posing the question and answering. So I have a question for Sonia, and it's a very interesting one, which is there any advantage of using CAR T anti-HER2 low affinity or medium affinity versus high affinity?
Yeah, there are advantages. Actually, for our clinical trial with CAR T cells targeting HER2, we are going with a low affinity CAR T cell because HER2 is also expressed in healthy tissues. So we have seen that low affinity CARs can differentiate between healthy tissues expressing low levels of HER2. Our low affinity CAR T cells do not recognize healthy tissue, but they can recognize high levels of antigen expression in tumors. So tuning the affinity is a way to target tumor antigens that are expressed in both settings. That said, I will answer with these other questions. We are using a 4-1BB base CAR, and in the project I show you, we tested for a CD28 base CARs that are more sensitive to the PD-1, PD-L1 inhibition than 4-1BB base CAR. So for our clinical trial, we're going with a low affinity 4-1BB based CAR, and then the 4-1BB base CAR is also resistant to PD-1, PD-L1 inhibition. And I didn't show this data, but... And I also want to mention I have answered some of your questions in the chat, whatever I had time to do.
Thank you. Do you have done any remaining question for Tobias while I look for questions for David?
Yes, I do. So, Tobias, can you imagine a scenario in which you use different CAR cells in combination, such as CAR T cells and CAR macrophages?
Yes, we do this. So this is active research that we are doing at the moment. And the first insights, they definitely support each other. What is the best combination and so on and so forth is unclear at the moment, but this is definitely active research.
Great. I found one question for David. David, thanks for the great talk. Have you checked whether LAMPs interact with CAR T cells and how it may affect CAR T cells phenotype or functions? I am also wondering whether you have found subsets of macrophages that possess enhanced immunosuppressive capacities in your single-cell RNA dataset. Because CSF1R is a broad marker for many myeloid cells.
Yeah, so for the first question, we try to address this with our co-culturing approaches, where we co-culture those LAM cells, which we ex vivo generated with CAR T cells. And here we found, as I mentioned, for example, this PGE2, EP2, EP4 finding, how they suppress CAR T cell function. So we used their flow cytometry in our co-culture. And that's a very good point. We are currently so including more patients. We have included 7 patients in this project, but the amount of LAM cells, we have to increase the amount of LAM cells to do subpopulation analysis, like Nicolas is asking for. So can we differentiate it or find different CSF1R positive, negative clusters, and how do they impact CAR T cell function? That's current work.
Thank you, David. Maybe one final question for Sonia, one final question for Tobias, and then we finish the session. And this final question is still from Laura. And she says, according to the data presented for solid tumors and hematological malignancies, I noticed that the CAR construct using solid tumors assays include a CD28 activation domain, whether the other construct contains a 4-1BB domain. Is this based on studies showing improved response with these domains? Is there any immunological rationale behind this difference?
Yeah, in our first project with ARI3, we actually tried all the combinations. We saw that when both CARs have C28, that's not a good combination. The best combinations were when both CARs have 4-1BB or when C19 had 4-1BB and BCMA had C28. But because we didn't see an improvement of having 2 different costimulatory domains versus both having the 4-1BB, we went with both having 4-1BB because these CAR T cells have already been approved in Spain. So we already know the safety and efficacy of these CAR T cells, and we went with that. For the second project, as I mentioned before, we tested both C28 and 4-1BB base CAR, but it has been previously published that 4-1BB base CARs are more resistant to PD-1, PD-L1 inhibition. So in this project, we focus on C28 base CARs and focusing on the affinity of the single chain FB.
And one final question for Tobias. So if you imagine injecting the cells directly into the tumor, what are the side effects of CAR T cells versus NK cells? Is there any concern regarding inflammation or autoimmune disease?
So far, actually, both with the cell therapies and with the cytokines, in all the clinical trials that have been conducted, there are no side effects, surprisingly. So it seems that a microenvironment is so immunosuppressive that basically the immune cells are rapidly inhibited, and the balance is really on the immunosuppressive side. We have also conducted clinical trials with cytokines directly. We have not seen side effects for glioblastoma patients. So it seems to be a completely different situation compared to hematological malignancies.
Thank you very much, Tobias.
Thank you so much.
Shall we maybe finish here, Andrew?
I think that's good. Thank you very much, everybody. It's been excellent. Lots of questions. I posted a few links to upcoming events from each of the societies. So it sounds like there should be quite a lot of interest in those events, given what we've heard today and the questions that have been asked. I'm sorry if we didn't get round to answering your question. We'll see if we can do anything about that later. But yeah, that's it from me. Maria, do you have anything you'd like to add?
Nothing, just to thank all the people that joined. We had a record of participants. We are very happy about that. Thank you as well to yEHA and yEFIS for joining efforts together with us. Tobias, Sonia, David, amazing talks. I think we are all convinced that we are going to hear a lot about CAR T cells for solid tumors and improved CAR T for hematological malignancies. You are, the three of you, doing amazing work. And we will keep reading and loving immunology and CAR T papers. Thank you very much to all of you, and see you very soon.
Thank you.
Okay, thank you
very
much
Thank you so
to all of
much.
you.
Bye.
Bye-bye.
Thank you very much, all of you. Bye-bye.
Thank you.